Hello, everyone. My name is Leora Halperin, and I'm an Associate Professor of International Studies and History, the Jack and Rebecca Benaroya Endowed Chair in Israel Studies, and the Director of the University of Washington Israel Studies Program. I'm pleased to see more than 50 people in attendance tonight. The University of Washington acknowledges the Coast Salish peoples of this land, the land which touches the shared waters of all tribes and bands within the Duwamish, Puyallup, Suquamish, Tulalip, and Muckleshoot nations. This event is made possible through the generosity of the Jack and Rebecca Benaroya Endowed Fund for Excellence in Israel Studies, and is co-sponsored by the Center for Studies in Demography and Ecology and the Population Health Initiative at the University of Washington, and by Americans for Ben-Gurion University. This event is also made possible by the generous support of the community of donors of the Strom Center for Jewish Studies. Many of you are in the audience today, and on behalf of all of us, thank you for your generosity. In particular, I would like to thank Becky Benaroya for her vision and leadership in making the Benaroya Lecture possible, and for allowing the Strom Center to reach more students and community members than ever before with programming related to Israeli society, culture, history, and politics, and today also medicine and public health. Becky, we're so happy that you're in the audience today. Today's talk would also not be possible without a group of professionals at the Strom Center who work every day to bring quality, thought-provoking, and academic programming to new audiences. These professionals include Sarah Zadis-Rosen, Kara Schoonmaker, and Grace Elizabeth D. In order to keep the focus on the presentation, attendees in this Zoom webinar do not have video and microphone enabled, but I welcome you to submit questions via the Q&A function at the bottom of your screen, and you can do that at any point or at the end of the talk. Dr. Davidovitch's lecture today will be about 30 minutes, and after that, Dr. Flaxman will provide a response. Following that, at around 8:50 p.m., we'll have an audience Q&A. So let me introduce our two speakers today. Nadav Davidovitch, MD, MPH, and PhD, is an epidemiologist and public health physician. He is the director of the School of Public Health at Ben-Gurion University of the Negev in Israel. He teaches on health policy, public health, health promotion, the Israeli healthcare system, public health ethics, and global health. He is also affiliated with the Center for the History and Ethics of Public Health at the School of Public Health, Columbia University in New York, and with the School of Public Health at the University of Illinois, Chicago. Abraham Flaxman is Associate Professor of Global Health at the Institute for Health Metrics and Evaluation here at the University of Washington, where he is currently leading the development of new methods for cost-effective analysis through microsimulation. Prior to being a professor, Dr. Flaxman was a postgraduate fellow at IHME, and before that, he was a postdoctoral fellow at Microsoft Research. Originally from Evanston, Illinois, Dr. Flaxman earned his BS in mathematics from the Massachusetts Institute of Technology. He earned his PhD in algorithms, combinatorics, and optimization from Carnegie Mellon University in 2006. Dr. Flaxman has written his popular blog, Healthy Algorithms, since 2008, his posts cover mathematics, computer science, and his research at IHME. So thank you for joining us, and I'll turn the floor over to Professor Nadav Davidovitch.
Thank you so much. It's a great honor to be here with you today. I became involved in pandemics about 20 years ago. Actually, the background you can see here below is when I took my first vaccine by the end of January 2020 at Soroka Medical Center, that it's a university-affiliated hospital located in the Negev. And I think that I can say, like all of you, that the last almost 2 years now have been like a roller coaster for me. As I said, I'm dealing with pandemics, both as a public health physician. I served in the military as the head of the epidemiology section in the IDF. I was in the Ministry of Health when we started to implement the international health regulations. And you can never envision how finally, when a pandemic like that happened, how things are going to be. And probably you can imagine that in many ways this is beyond our imagination. And I need to say also that as someone who implemented the international health regulations and established in Israel with my colleagues a field course on epidemiology, dealing with emergencies. It was very, very frustrating to see that when Israel and other countries started to react to the pandemic, this was actually almost like throwing to the garbage many of the things that we were preparing. During the first wave in Israel, we were very quick to close our borders, and this created a situation where actually we got a relatively small first wave, but things were very, very centralized, and all the structures that actually were needed to be taken in place only started to operate later. I joined the National Advisory Committee in Israel on June 2020, and since then we started to work in a much more organized manner. So actually in the first slide, I'm showing a caricature from 1892. And the pandemic the trendy pandemic then was cholera, actually. And what you see in this caricature, you see Uncle Sam watching behind the walls, and it's written close to immigrants from cholera-stricken countries. And there are several newcomers. One is death representing cholera. It's written Asiatic cholera, maybe reminding us of the Chinese disease, or this kind of labeling that we had throughout history, the Spanish flu, and this idea that there is some specific origin that, of course, many times it's quite dubious. And then you can see two immigrants, one probably German, looks a bit drunk, and the other one, a very typical anti-Semitic caricature of Ostjuden, the Jew from the East, with the nose, all the typical ultra-Orthodox kind of characters. And I'm mentioning it because I think in this caricature, it captures many of the tensions that we see throughout history in epidemics, in pandemics, and maybe some of the wrong interpretation of public health that unfortunately physicians and the public all together are taking. And this is the whole idea about public health as protecting us versus them. So mainly the exclusion part of public health. And throughout the pandemic, also before that, but also during the pandemic, I was trying, as maybe one of the public figures in Israel, working quite a lot with social media and the traditional media. I was trying to present, and this will be maybe one of my main messages today, a different perspective of public health. Public health that is not about us versus them, about the other. It might be the migrant, it might be people from certain ethnicities related to the different contexts in different countries, but public health is related to human rights. Public health as inclusion. Throughout the pandemic, I heard lots of metaphors, many of them coming from military metaphors, or metaphors such as ticking bombs, people, human beings as ticking bombs. This was mentioned in Israel, for example, regarding ultra-Orthodox, and especially during a very intense political situation. If you remember, Israel went through several elections in an unprecedented way. And during the high holidays of the beginning of, relatively beginning of the pandemic, the second wave, we had enormous tension between the question of synagogues and praying, very high rates of infection in the ultra-Orthodox community, and demonstration then against Netanyahu. This was extremely intense, and I felt I was trying to do negotiation among the different parties. During the last almost 2 years, I was in dialogue with the ultra-Orthodox media. Just 2 days ago, I came to Kikar Shabbat. Maybe some of you know it's an ultra-Orthodox, more Sephardic program to discuss issues of COVID, and this became something that was very important for me. Another context that I want to mention here that is very unfortunate is the current threat on public health officials. The current head of the public health services in Israel, Dr. Sharon Alroi, is now escorted by police. There are many threats by anti-vaxxers. I myself being depicted as Dr. Mengele in my Facebook account. It was mentioned there that I killed more people with the vaccines than in the all Israeli wars and all car accidents all together. This is the atmosphere, and I think that's something we need to think. But this is not new. This is a caricature from 1916 about anti-vaxxers and the medicalization of public schools. So I'm not in the same thread like Dr. Sharon Alroi, but this is the context that we are making our decision right now. As the chair of the Israeli Public Health Physician Association, we were pushing to have open, transparent discussions. I'm a very close friend of Professor Arnold Monto, who is the chair of the interim committee on COVID vaccines in the FDA. And I must tell you that there are probably many things that I don't want to learn from the US healthcare system, being very fragmented, lots of inequities, mostly private system, no national health insurance law, things that we have in Israel. And thank God this was extremely helpful during the pandemic. But something that I mentioned that we should take from the US system is actually the transparent discussion of the FDA, CDC. So we had a first open discussion of the expert committee regarding children vaccination. And because of all the threats, finally it was decided to close the second discussion. I think this is very unfortunate. So what is the situation currently in Israel? So I think that this is very mixed. Throughout the pandemic, as I mentioned, we had a very fragmented political system. And I'm doing now currently study with my colleague, Professor Moria Eden from Ben-Gurion University, about the role of scientific committees advising to the political system. Now, I can tell you a lot of anecdotes and frustrations about these kind of processes, but there is something that I really want to present here that maybe other people and maybe AB later can comment. I think it would be very naive to think that we can differentiate between politics and scientific decision making. Finally, science, of course, based on different disciplines and methodologies, is extremely crucial. But finally, we must understand that politics is an inherent part of the social determinants of health. And for example, when we started to make analysis of the situation between the first and second wave, we suggested to have what is called a traffic light system, now being adopted in many, many different countries. And we had lots of pushbacks from different communities, including the ultra-Orthodox communities and also the Arab community, because it was clear that having a traffic light system that is based just on the number of COVID cases, this might be maybe good from an epidemiological perspective, but this does not include all of the social, mental health, and other power imbalances. So the idea of having a traffic light system based just on epidemiology was indeed very problematic, and it makes that it probably showing us that when having a scientific discussion, it's very important to get the input from different parts of society. And I think this is just showing us how finally it's important to integrate between epidemiological or other scientific committees, and also the being part of the political system, not politics related to different parties, but actually politics as related to power relations, to power imbalances. And this is leading me to another major point that that of course the cliche that disease no borders, and that the virus is finally infecting all of us. So this is probably very, very simplistic. And what we saw in the Israeli situation, and we saw it all around the globe, that it's a very crucial connection between social determinants of health, issues such as housing, employment, poverty. All of them are extremely important when dealing with the pandemic. And we see the data in Israel that finally several groups actually were hit much more in the Israeli context. This is true, of course, also in the US and many, many other countries. And for example, when we are talking about presenting the data to decision makers, I was trying to make the case that in the dashboard that is presenting the data, we must include not just the number of COVID cases, but we must include also unemployment. We need to include issues such as how many days schools were closed, because it's also had a very important effect on children. I think that gradually we are understanding now that the influence of the COVID pandemic is going to stay with us, of course, for many, many years to come. We have the question of long COVID. We have the mental health, the social and economic aspects. And here, the approach must be very, very different, and it's related to the first slide that I was presenting to you in your kind of imagination, let's say, that it's not just epidemiology. The socio-political processes are not less important, and of course are related to the different context, political context, historical context in different countries. So take, for example, the question of vaccination. So in Israel, vaccines are available for free, like in many other countries, including in the US. But if you're taking a very passive perspective on vaccination, you can see that finally, even though vaccines are available for free, when just suggested, there are going to be large gaps in vaccination rates. And indeed, the situation in Israel right now, both with the first, second, and third dose, that we see that there are large inequalities. The current government and the new Minister of Health, Nitzan Horvitz, that I know from many years, working with him on, especially on environmental issues, he started a much more targeted approach with the mobile units, and also with a very strong collaboration with NGOs and civic society, working with religious leaders. In the Negev, in the south of Israel, we are working with the Israeli Arab Physician Association. There are now more than 700 Bedouin physicians, including women, and that's of course a major change in the last decade. And we're working together with them and with the religious community, Muslim religious community, with ultra-Orthodox leaders, and trying to target those who are not vaccinated, not just as a monolithic group, but trying to work with mainly the larger group that are vaccine hesitant. And indeed, in the last few months, there is a great improvement in getting into these communities that were hard to get. Still, there are gaps in vaccination rates, and I think that it's also giving us the message that legislation should be very different. For many years, public health services, including in Israel and then also in the US, were neglected, and this is, of course, an opportunity. I think that the current situation of COVID is actually showing us a mirror about the structure imbalances in our society, both within the healthcare system and outside the healthcare system. And of course, when you're getting these solutions such as online learning, of course, there'll be gaps in connection to the internet. There'll be gaps about health literacy. And when we started the pandemic, it was ironic that there was a state controller report about dealing with epidemics, showing the neglect for many years. And it's very unfortunate that we needed to have the pandemic in order to start to understand how this investment might be possible. So the COVID pandemic is not just about COVID. It's not just about counting cases. It's about structural issues. It's about racism. And I think that we have here an opportunity to make a major reforms, both in the healthcare system and outside it, including strengthening public structures that I think for those who maybe were counting on some neoliberal approaches about privatization, actually we saw now, and in Israel even people from the right started to embrace the public healthcare system, including ideas such as nationalizing vaccine production. And I think this is a very interesting turn that hopefully will serve us in the future. I'm not naive. Many times, you know, when we are returning from such a crisis, we can usually see that we can get back to all the structures. But these inequalities, of course, are not just on the national level. There is a relatively new report by the European Commission, headed by the previous Prime Minister of Italy, Monti. He is a health economist. Sorry, he's an economist. He was asked to chair this committee, and at the beginning he said, "You know, I'm not a health economist, so why do you think I should be the one?" But I think this was a very important decision. And in the report, at the beginning, in the introduction, Monti is actually talking about the chronic problem. First of all, the short insight we have that we are not investing for long term, and there is what we call the paradox of prevention, that prevention is always a kind of neglected. Prevention is not sexy. Prevention is usually, if it's successful, nothing happened. Okay, so it's very hard for the politician to show the success. So although social, political, environmental determinants of health are mainly those who are defining our health, and healthcare is maybe responsible for about 10 to 20% of outcomes, health outcomes, most of the money is finally going downstream to healthcare. I'm not against healthcare, of course, but the balance, of course, should be different. So this is one chronic condition problem that Monty was showing in the report. And the second problem, that we are taking international or global issues such as the pandemic, and probably much more important now, issues such as climate change, and taking a very narrow national perspective. And I can give you many examples related to COVID, but probably the most important one is currently about vaccination. We need to move from vaccine nationalism to vaccine internationalism. I'm on the European task force for the Association of Schools of Public Health in the European region, and we are fighting to see how we can deal with the current market failure of the pharmaceutical industry, that we saw that every country is doing its own contracts, secret contracts, that finally are a very strong barrier for vaccinating around the globe. The gap now between different countries in vaccination rates is not morally wrong, but it's also very bad from a utilitarian perspective, because this is a very fertile ground in order to see how we can deal with the pandemic. It's a fertile ground for variants. And on the regional level, all of our public health communities was proposing that we must take care of vaccinating also the Palestinian population. They are our neighbors, and we are not an island. Israel is not an island, and we can see the different influences if we're not going to see the Palestinian Authority being vaccinated. Unfortunately, because of my mistrust, there's still lots of issues. The current Minister of Health, Nitzan Horowitz, is having a much better collaboration with them, and I hope there'll be such a change. We recently published a paper learning from COVID how we need to deal from these issues from on the regional level, learning how to deal with climate change. So the main message is that COVID-19 is a mirror reflecting previous problems in our societies. There are some global issues and some that are more related to the local context. And the best approach would be dealing with the pandemic from what we call health equity in all policies. And the main challenges is to see how to integrate among different sectors. The second message I want to convey, that the cliche that disease knows no borders is very problematic, because COVID-19 is any other disease affecting disproportionately vulnerable groups. And this is something that we need to address in a very proactive way, because if things are very passive, again, there are many market failures and many power imbalances that are going even just to increase inequalities. And the final message that I want to take from Professor Alan Brandt from Harvard, the well-known historian of medicine and public health, who was my advisor on my PhD. When he was asked by Gina Kolata, a New York Times commentator, health commentator, when we're going to see the end of the pandemic. So he said, and I'm saying it also as an epidemiologist, that this is not for the epidemiologists to decide. We need to be very, very humble we need to remember that throughout history, these kind of decisions about when epidemics end, when pandemics end, are finally much related to much larger socio-political processes. And I think that having an intersectorial approach with disciplines from social sciences and humanities, I think this is one of the current challenges. I don't think in Israel we're doing it enough. I'm trying, as someone with a PhD in history and sociology of science, I'm trying to bring this approach from time to time. But I think this should be a much more structural question, how these are going to be represented within decision making, how different parts of society must be integrated in decision making. In one of our studies on brucellosis, an infectious disease transmitted in raw milk, very prevalent in the Bedouin community, we were doing anthropological observations and interviews, and we saw the importance of mistrust. And we call it sometimes circular mistrust, how the public not trusting the government. In the case of the Bedouin community, years of neglect. So when they see that vaccination are there, they're asking, why you're just interested now with us? You want to vaccinate us because you are afraid of being infected. What about our sewage? What about the infrastructure? But there's also mistrust from the government and the health community sometimes within these communities, again, about fake news, accusation of some communities being so-called irrational. And in our work, we saw that if public health is interpreted not just us and them and protecting us versus them, but is related to the role of the state, the role of society, the responsibility to implement the right to health, to see how we can use solidarity, not solidarity that is just about people that look the same, that are from the same community, but pushing forward with the solidarity to see how we can include other groups and human beings in general. I think this is probably one of the most important challenges facing public health and I think societies in general. And I can assure you that we are learning to live with COVID, and I'm much less preoccupied with that. Of course, still COVID is all over. There are more than 5 million people and probably more that are dead around the globe. But I think that the current challenge will be the issue of climate change, including climate change and health. And as Monty said in the EU report, we cannot take it just as a national problem, but we need to see how together we can work to improve different policies and reduce inequities both within countries and between countries.
The comments on that I've been preparing really start from just saying, so much of that hits so true here as well as there. Politics are so key to social determinants of health and to how this epidemic is going. This targeting of leaders is really pernicious and something that we have to watch for. And I want to come back to that also because it's not just the leaders. This is really burning out the rank and file of our public health and healthcare workforce as well. And like you said at the end, COVID-19 really is a mirror. And I'll go further to say it's a mirror and a spotlight shining on all of these existing social inequities. I do have a few slides prepared. My first one just says that, first of all, this research that I'm going to present to you was conducted on the traditional lands of the Coast Salish people. And secondly, my grant and research support and consulting is also listed on this. Now, the University of Washington has an institute at which I work called the Institute for Health Metrics and Evaluation. And before COVID, the main thing that we worked on there was called the Global Burden of Disease Study. So this study attempts to make comprehensive estimates of mortality and morbidity of major diseases, makes them at the global, national, and regional levels, and makes them comparable over time and between places. And so the kinds of things that we found doing this in the past are summarized in a picture like this. This is a tree map of the composition of global burden of disease back before COVID. And so you can see in the different areas of these different rectangles how bad, say, ischemic heart disease is. And you can compare that by size to how bad road traffic injuries are. This is actually an interactive tool you can find on the web if you search for GBD Compare. But because of the history at IHME of doing this kind of descriptive epidemiological work, when COVID hit, we were in a good place to start applying these tools to making estimates at the national and global level. And so epidemiological modeling people all turned to looking at COVID-19. And what this is showing you is really the key point that we are finding in our research, which is COVID is not over. You can see that that started before today, but as the animation passed today, things continue to darken. And that is because COVID, in this case, deaths, are continuing to increase, we think, over the winter and even into the spring. This is such a problem because we have effective tools for stopping this. We had tools early on, like social distancing, but now we have pharmaceutical options like vaccines. And so if you look at the COVID-19.healthdata.org website, you can see all of the data that we put together and the estimates that we make from it. For example, showing how Israel early on was able to really fast scale up coverage of vaccines. And if you can remember back to, a year ago this time, we were really hoping that vaccines were coming soon. And as we were getting out of last winter and into last spring, coverage of vaccine, at least one dose in Israel, was hitting 60% in April of 2021. Now in the United States and in Washington State, where I am, and I bet many of you in the audience are, we were way behind at that time back in April. And we should note, of course, as Professor Davidovitch said, Israel is not an island. Palestine at that time had very little vaccine coverage. But you can also see over time how all these things have scaled up. And some of these issues, such as vaccine hesitancy, have both prevented the United States as a whole from making it to Israel levels for a very long time, and also have prevented Israel from keeping pace with Washington State, which now among these comparison pieces is really a front runner. Of course, it's not just a matter of who is willing to take the vaccine. There's also the question of vaccine supply and many other factors in play because politics are part of the social determinants of health. You can see, for example, even now that the coverage in Israel is more than double what's happening in Palestine. This plays out also when we look at the case curves. And I'm sure everyone has looked at curves like this. This one, for comparison purposes, shows the confirmed infections per 100,000 in Israel, and comparing that with what's happening, say, in the United States or in Washington State. You can see that now in, say, which one are we looking at now? The United States as a whole, there are more confirmed cases per day, similar in Washington and in the United States compared to Israel. And actually Palestine is similarly confirming a small number of cases per day. If you look at this blue line out towards the end here, which I'm having trouble showing without the little numbers covering it up. But confirmed cases can be hard to interpret. And that's because how many cases you confirm depends very much on how many tests you are doing. So if I switch this view to look at tests, you'll see that in Israel, there are a huge number of tests happening, much more than is happening in the United States, which actually in this case, Washington State is doing a bit less than the average across the entire United States country. But in Palestine, there's nearly 10 times less tests happening than in Israel. So if you see similar numbers of confirmed cases in one place than the other, that could still mean that there's a lot more infection happening. And a lot of the work that we've been doing at IHME is to put together all these different sources of data to be able to make our best estimates, imperfect as they may be, of what's happening in the parameters we're really interested in, such as actually infections. And so what we see is that once we've done that transformation, actually, it seems like things are doing pretty well in terms of infections, relatively speaking, in Israel, and also at this point in Palestine, as compared to what's happening here in the United States, or even in our own Washington state. And there's a lot of factors that play into this. Some of the ones that I think are most important are, let's see, the other things I wanted to show you were some other ways of looking at all of this, which I'm going to skip. I'm going to just allude to quickly. If we're looking in King County at what's happening, we can look at hospitals now, which is one way to keep track of things. And this gives us a much more direct measure than the kinds of case curves that we're estimating, but shows a similar sort of story, that things are much better than they were at the peak of this Delta wave back in the late summer, early fall. But they're not down to the low levels that we've seen previously, or the pre-COVID kind of levels that I was really hoping at this point we would be down to. And for those of you calling in from the University of Washington, the University of Washington actually has done a very nice job tracking what's happening on campus with this Husky Challenge Husky coronavirus testing program. It's a little bit hard to interpret this, but basically there's about, it's going to reload and then it'll be hard to interpret this. If you look at the number of negative tests, we're testing a sample of students every week, and around 3,000, 4,000. It's been a little bit less lately, 2,000, 1,000. But if I get it to just show positive tests, you'll see out of those thousands per week that are being tested, we're finding 8 people test positive. And this isn't biased in the way that some of those testing curves we were looking at before are, because we're attempting to take a representative sample of students. So we can say from this that actually on the UW campus, we're doing a pretty good job keeping COVID in check. And on the other hand, it's not gone. COVID is still here. So I think that comes back to the main point that I wanted to communicate in all of this, which is COVID in some form is here to stay. And whether that's like there's this new malady that's kind of like flu, it has some seasonal problems and it's COVID, or whether it's like there's a 5th wave coming, that really is up to us. And not just us like me and you, mass behavior, but also us like politics are part of the social determinants of health. And so in these 3 different scenarios, we're saying, well, green is what we think is going to happen probably from what we've seen before. Kind of, I don't know, what should we call this color? Mauve is what would happen if everybody would really do their best to make a difference here, while salmon is what happens if vaccinated individuals stop wearing masks, mobility increases among those who are vaccinated and those who are not vaccinated, and new variants emerge, which fortunately since Delta, we haven't had any disturbing changes in variants, but viruses evolve. There are going to be changes, and what happens with those, we shall see. So there's some other points that are not captured well in all of this that I've talked about, and I think Professor Davidovitch did a great job doing those. I won't belabor this. And most important thing that probably, if we can get the professor to come back with his slides, he can share some new evidence from Israel about, is this question of waning immunity. You've heard people talking about a single dose or fully vaccinated. I'm predicting we're not going to be calling 2 doses fully vaccinated for that much longer. And I think that this limited information that Eric Pelpel calls out the New York Times for sort of just showing a handful of studies when there's many more out there, when my colleagues have been putting together all of the studies out there that they can find, they find that waning is a pretty consistent finding, and that maybe 6 months, maybe 9 months after you thought you were fully vaccinated, well, hopefully you're still somewhat protected, but as far as being able to transmit the disease and infect others, it might be similar to when you weren't vaccinated at all. So on that note, I will wrap up and hand things back over for discussion or maybe some additional slides. But just in conclusion, COVID is not over. Vaccines wane. And this is a marathon, which we're going to have to keep going on. I'll leave it there for now.
Now, in terms of waning immunity, I just need to say that we prefer even not to call it now booster. We think that in Israel that this is the schedule, with Pfizer at least, that you need to give 3 doses. At the time, by the end of July, beginning of August, it was very hard to make the decision. And I'm glad we did it even before the FDA, because it's clear now that waning immunity with Pfizer is taking place in all age groups. And as Abby showed before, without the 3rd dose, you get down to about 40% protection. And of course, it's much better than not vaccinating at all. But with the 3rd dose, you can get back to 95% protection, both reducing infection and transmission, but also hospitalization and deaths. But again, vaccines are not going to solve all of our problems, not going to solve the long COVID, not going to solve the mental health aspect, unemployment, the social and economic, and the non-COVID things that were neglected during the pandemic. So we need to learn to live with the virus, with COVID, and move forward to sustainable solutions that will include, for example, climate change and health that are much more preoccupied with. Maybe just to finish saying that I mentioned that we have a study about the relationship between the political stability and the trust. And I think that's also an interesting direction. We see what's going on now in Eastern Europe, and probably the mistrust with the state and the post-communist era is something that is also very important. So vaccinations are not enough. Even having vaccine all around the globe will not be enough. But we need to see how we work on it together. Thank you, and I'd love to answer questions. And I'm happy that I proved you that I had a proper presentation.
Thank you. We're so glad that you were able to show some of that material. And again, thank you to you both. So I'm seeing some questions coming in from a variety of attendees. So we have some interest in vaccine access in middle and lower income countries. So I'm going to ask 2 questions together that both pertain to this issue. One from Melissa Upton, who says, until we have global vaccination, we will continue to have new SARS-CoV-2 variants. Can you address how countries like the US and Israel can contribute to increasing access to vaccines in middle and lower income countries around the world? And Amy Hagapian asks, relatedly, is Israel supporting the waiver of intellectual property protections for COVID vaccines at the World Trade Organization that would allow low-income countries to make their own vaccines?
So I think this is a crucial question. I signed several petitions, both in Israel and to international ones. I think that the current system is totally not sustainable. We have a market failure. And I just want to bring an example how in about 70 years, we moved from Jonas Salk saying, can you patent the sun, when he was asked why he's not writing a patent on polio vaccines. And in several decades, we moved into almost exclusively kind of a private funding. That's something that is totally intolerable. But of course, this will take time and political will. On the short term, there is the COVAX agreement. Israel is signed. We are donating, but not enough. And again, within the region, I think we have a responsibility for our Palestinian neighbors because of the history, because of the conflict, and also because they are close to us, So I think there are short-term solutions, and the long-term must be a very different approach to the pharmaceutical industry.
Thank you. We have a question asking or noting that Israel's approach mirrored that in the US by focusing on shutdowns and social distancing, masks, and then vaccines. In your talk, you made no mention of early treatment and therapeutics. And this person asks why, especially given promising therapeutics used elsewhere, was this not pursued more aggressively?
So I'm happy that there are now new drugs. There is a variety of them. This is not going to solve the problem. Prevention is always best. Vaccines, of course, and also non-pharmaceutical intervention, as Abby mentioned. I think, of course, you need to balance and be proportionate. And sometimes we got into lockdowns that maybe were necessary, but I think that always lockdown is a failure because if doing contact tracing and breaking chains of transmission and masks and hygiene, ventilating the classrooms, etc. International health regulation, you can at least move forward and try to prevent as much as you can. There is no magic bullet. There is no magic drug. I think drugs are important part of a multi-layer approach because some people maybe cannot be vaccinated, or some vaccinated and it's 95% efficacy, so 1 out of 20 are going to be sick. But as we both said, the social determinants of health approach is crucial here, and it's always tempting to think that there'll be like a magic bullet, but things are more nuanced and complicated.
Thank you. We have a question from Ayel Mador, who says, I'm heartened to hear Professor Davidovitch emphasize solidarity beyond borders and the role of political decisions in health outcomes of vulnerable populations. What is your perspective on the advocacy of human rights organizations around lifting Israel's siege on Gaza? And this person, Ayal, notes that Israel's policies in Gaza has restricted import of fuel and materials that Palestinian hospitals need and has limited the enclave's COVID-19 response.
So I'm volunteering with Physicians for Human Rights already for 20 years, even when I was in the military. So you can understand the Israeli society complexity. I totally agree. I think from a human rights and public health approach, we need to see how the siege over Gaza will be lifted. I think that, again, like vaccinations, this is true from moral perspective, but also even from utilitarian perspective. I wrote a report with EcoPeace showing that if the situation will continue in Gaza, finally, it will be intolerable to live there from an environmental degradation perspective even. And we can see finally environmental refugees just going, and I'm not talking now about terrorism or something like that, just people that cannot live because there is no available safe water or living conditions. So it's of Israel's interest to see how to deal with the current situation. It's very sad. Physicians for Human Rights are maybe the only Israeli NGO that's still entering Gaza about once a month to bring supplies and also doing training. But even Physicians for Human Rights sometimes are boycotted by several Palestinian organization because it's an Israeli organization. So I think it's more complicated than just one side this and one side that. Palestinian society is not monolithic. There are many different components there, but in general, from a public health perspective, I think that the siege is intolerable from a public health perspective, and we need to find solutions.
Let me ask, I think, just one more question from Kathleen Spitzer, who is a great friend of Ben-Gurion University and has been involved in this area in connections with your university. So she asks, she's curious about patterns of vaccine avoidance in Israel. She says that she's heard from friends that people on the left politically rather than the right are more vaccine hesitant. You also mentioned various other populations that have patterns of vaccine hesitancy. And I'm just wondering if you could sketch out a little bit further, like what are the patterns around vaccine hesitancy that you've observed?
That's a fascinating question. We're doing research on that. So there are different groups with different kind of fake news about fertility, other things. On the political level, it's really strange even, or ironic, I don't know how to say, that some part of the left, some parts that were demonstrating against Netanyahu and felt that Netanyahu use of the vaccine is a political use, and they became also against vaccination. Now, not all of them, and now there's a crazy rift among those who were demonstrating, some of them supporting vaccination and some against. I can send you materials on that. AB, not AB Flaxman, but a very famous activist in Israel. He has a Facebook radio show kind. He's someone who's now, he's a great supporter of vaccination, and he's totally furious about his comrades that were demonstrating against Netanyahu. And believe me, it's an amazing study in sociology of Israeli society. There also was a study showing that during Netanyahu regime, vaccination rates among Likud supporters were higher, and now with the first and second dose, and with the third dose, they became lower because now it's being related to the current Prime Minister Bennett. So you can see the politics of health, and human beings are not so rational all the time, and that's something that we need to say. But Liora, in general, Israeli society is very supportive of vaccination. It's embedded in our culture, even before the state, as part of even Zionism ideology about progress. In Alt-Neuland, the book of the utopic book of Herzl, he's depicting in the beginning of the 20th century a new laboratory with producing vaccines. So most Israelis are supporting vaccination from both right and left, and even they interpret it also not just on the individual level, but on the community level as part of solidarity. So anti-vaxxers, really hardline anti-vaxxers, are very few percent. There's about 20 to 30% that are vaccine hesitant. And here you need to differentiate. And again, I mentioned the Bedouins, the ultra-Orthodox, and the different issues.
And I just wanted to give Professor Flaxman a chance if there were any of those questions where you felt like you had something you wanted to put in before we close for the evening.
There are so many parallels to what's happening in the United States and all of these things. Just tagging on to the last one, I think that the most important thing I feel in studying kind of vaccine hesitancy is to remember that this is not a monolithic group. And there are so many different reasons that people have not gotten their vaccine yet, from like they're afraid to they think it doesn't work, to they just haven't had time. But from those who are really refusing the vaccine, not because they don't have time, there's still so many different perspectives to why. And in the United States and in Israel, and I would posit really in everywhere, it comes down to trust. If there are trusted intermediaries who are part of whatever community has this hesitancy, they can bridge that gap. So, I'm looking around in the Seattle area to see what's happening. And there are great groups like the Somali Health Board that are working hard to bridge gaps to communities that have traditionally had a hard time accessing medical care here. And I think that these kinds of very custom tailored approaches are what are going to get us that last mile in vaccines. But going back to things we've said earlier, it seems at this point, even getting that last mile of vaccines might be ending a pandemic. It's not ending COVID. So we've got a lot to do wherever we are. Thanks.
Thank you. Thank you so much. So I just want to thank you all the attendees tonight for joining us, and also for our community supporters and donors who make this event possible. I'd like to invite you to save the date for the University of Washington's 9th annual Ladino Day celebration on December 12th, where editors of the new book, Sephardic Trajectories, Archives, Objects, and the Ottoman Jewish Past in the United States, will discuss the book project alongside presentations from 3 contributors to the volume. So we will now end the webinar. Thank you.